Hi, I'm Don Berwick. This is a confusing time in healthcare policy, to say the least, and I thought I might try to do a little bit of a primer that would give you a better way to read the paper, a better way to understand what's happening in this American healthcare policy debate at this time. Of course, any day I do this, it could be wrong the next day, but at least as of now, here's how it goes. I'm going to begin by explaining the Affordable Care Act. Don't run away. Don't go to sleep. I'm going to try to do it really fast to tell you what happened in 2010 when this law got passed. The Affordable Care Act, passed in the spring of 2010, is actually two laws in one. It's under one title, and there are 10 sections of the Affordable Care Act. But the way I think about it, that law tried to accomplish two things for America. Thing number one was give people more insurance and better insurance. It's the insurance law. At the time the law was passed, about 50 million Americans had no health care coverage at all. And the intent was to make that coverage possible, and in so doing, make the coverage more effective. That's been the mainstream of policy that you've been reading about since 2010. How did the Affordable Care Act attempt to achieve more coverage? Two main ways. The first was to cover more people under Medicaid. Medicaid, of course, is the federal state partnership that was set up under the Title 19 of the Social Security Act in 1965, which established a partnership in which states could, if they wished, offer coverage to people who were of low income in the state and to people in nursing homes who were of low income, in partnership with the federal government, which contributed to Medicaid coverage. Each state got to index their coverage to its choice of degree of poverty. Using the federal poverty definition as 100%, the federal poverty limit, a state could say, we would like to cover with Medicaid anyone up to the federal poverty limit, or 120% of the federal poverty limit, or in some cases, 20% of the federal poverty limit. That was a state-by-state decision, and the feds would kick in a portion of that money. As a result, there were a lot of poor people, especially in states that had very stringent requirements for Medicaid eligibility. It left a lot of people out. The Affordable Care Act tried to change that. It said, we're going to allow Medicaid to expand, and instead of having variation across the country in eligibility, everyone up to 138% of poverty, including single childless adults, would now be eligible for Medicaid. And in the states that had different eligibility criteria than that, the Affordable Care Act said the federal government will pick up the difference. We'll pay the difference between whatever Medicaid population you're covering now and covering people up to 138% of poverty. That would be at 100% federal match for a period of 3 years or so, and then it would decline to 90% federal match. Through that mechanism, the Affordable Care Act intended to extend Medicaid coverage to about 16 million more Americans. The Supreme Court changed that in a decision after the passage of the Affordable Care Act. The court ruled that was too compulsory for states, that it was too much expansion of federal government influence, because the state under the Affordable Care Act had to choose between expansion or dropping out of Medicaid entirely. The Supreme Court said that was not okay, and states had to be given the choice about whether to expand or not. About 19 states chose not to expand. The remainder did. But the overall intent was to cover more people by expanding Medicaid with federal dollars up to 138% of poverty. The second way to cover people, which applied especially to people who didn't have coverage through the commercial insurance market, their employers, which is about 150 million people have that coverage, or through Medicaid or through Medicare, for that very special population known as the individual and small group market, to give them access to coverage that they otherwise wouldn't have had through state-level exchanges, marketplaces, which the states would set up, asking insurance companies to post opportunities for insurance on that marketplace, and for the federal government to give subsidies to people to buy that insurance, subsidies that varied with income from 138% of poverty up to 400% of poverty. The federal government would kick in some money to help those people buy that insurance. And with that extra boost and the existence of these marketplaces for the individual and small group market, about 16 million more people could have been covered. That would have covered 32 million people, 16 million under Medicaid, 16 million under the exchanges. It didn't go all that smoothly. First, in the Medicaid world, the Supreme Court said states don't have to expand, and some didn't. And in the exchange world, the marketplaces proved somewhat difficult to manage. And so fewer than 16 million people got enrolled. But overall, over 20 million people got coverage under the Affordable Care Act as implemented. One other technicality in the Affordable Care Act had to do with those marketplaces, those exchanges that were set up, because the government, the law had to make it mandatory for insurance companies to issue policies even to people with pre-existing conditions. Before this law, if you had a heart attack or were a known diabetic, an insurance company could say, we don't cover you. You're already sick. We only want to cover people who don't have such risk. The Affordable Care Act said that's not okay. We have to have guaranteed issue. So no matter what your health status, there has to be insurance available to you. Further, it said the premium for that insurance had to be community rated. We're going to have to pool people who are well and people who are ill. Otherwise, if your premium could be set at indexed to your pre-existing condition, the policy would be unaffordable to most Americans. And so it created pools of coverage, community rating that's called, with a maximum band of difference between the lowest premiums and the highest premiums. Well, you understand, if the insurance companies have to cover you, and if you're going to be included in a pool, then you have an option as a potential purchaser of care, of coverage, which is don't buy the coverage at all. Wait until your car hits a tree. If you're a 28-year-old and you're perfectly well, why would you buy coverage? And that led to the third part of this troika: guaranteed issue, community rating, and individual mandate. People had to buy insurance or they would pay a penalty. That was logically necessary because if well people can stay out of the pool, if we have guaranteed issue and only sick people are in the pool, the premiums are unaffordable. So the Affordable Care Act asked Americans to take responsibility for being part of the common pool for the insurance system. It also added one other provision, which was to cover children under the age of 26 on their parents' policies. So if you look at the overall possibilities, 16 million more people covered under Medicaid, 16 million more people covered under the exchanges, and 3 million kids covered under their parents' policies. That was the expansion of coverage that the Affordable Care Act sought to achieve. In the end, about 22 million people got coverage who otherwise wouldn't have had it. At the same time, the Affordable Care Act, in this insurance part of the law, made health insurance better. It added prevention benefits, first dollar coverage for preventive practices in the clinical office. It added prescription drug benefits for Medicare beneficiaries who otherwise were left in the so-called donut hole where they couldn't afford coverage and didn't have it under Part D of Medicare. And it also put insurance companies under some stringencies, not just guaranteed issue, but also made insurance companies become transparent about their premium increases. They had to post in advance what their premium increases would be. It limited the amount of money that insurance companies could spend on overhead overall to about 15% of the total bill. Before that, insurance companies often spent far more than that on their overhead. And it put special conditions on Medicare Advantage plans so that their costs, which had risen much higher than anticipated, would come back under control. That's law number one, covering more people with better coverage. The second part of the Affordable Care Act isn't about coverage. It's about healthcare reform. It's about making healthcare better. And there are many provisions in the Affordable Care Act to support that. Three general trends are: first, to support integrated care. That means to support teamwork, to change the way we pay so that hospitals and outpatient areas, so that population-based care and inpatient care would become much more team-based, much more integrated by beginning to pay for team-based care instead of silos of care. That's where the accountable care organizations came from under the Affordable Care Act. That's where bundled payment comes from. That's where some important innovations in helping care for very poor people who are very sick, the so-called dual eligibles who have both Medicare and Medicaid. Imagine that stressed population, about 9 million people. And it particularly supported transitions of care from institutions back into the community, new ways to pay for community-based resources to keep people at home where they want to be instead of hospitals. On that second part of the law, the better care law, the delivery reform law, there was a lot more emphasis in the Affordable Care Act on quality, new metrics of quality, much more transparency, paying more in hospitals for outcomes of care, for reducing complications, so-called value-based payment. And by the way, a lot of work on fraud and abuse. The Affordable Care Act gave the government an entirely new set of tools for detecting when thieves were out there trying to steal money from Medicare and Medicaid, and by inference from private insurers. The other thing this part of the law did was invest in innovations. It helped us begin to invent new forms of care in the country, better teamwork, better coordination, and it did that through a wholly new organization, the Centers for Medicare and Medicaid Innovation, CMMI. CMMI was given $10 billion over a 10-year period to help foster new forms of care around the country. It also set up a prevention fund to help us innovate in the very important area of preventing illness, preventing diseases. It fostered new forms of pricing, especially new bidding and auction structures that stood a chance of buying better care at lower cost. And it put a special investment into a very important form of innovation in our care system, and that is new forms of community health centers. That's the Affordable Care Act. Cover more people with better insurance and support the change of healthcare so it's more affordable and better for patients. It, of course, came under enormous attack right from the start, became the battleground for the political debates of the entire Obama administration. And now, with the new administration in place, there are efforts to change that, to take the Affordable Care Act away, to repeal and replace. At the time I'm speaking with you, it's America's Health Care Act we're talking about, passed by the House of Representatives and pending now in some form, perhaps, in the Senate. Well, what does that law do? Well, the way to understand it is with reference to what the Affordable Care Act did. Medicaid expansion, adding up to 16 million people. The America's Health Care Act ends that. It ends Medicaid expansion in states around 2020. States that haven't expanded will not be able to enter, and patients who haven't become beneficiaries in the expanded population can't be added anymore. And since the Medicaid population turns over over time, fewer and fewer people will be covered by Medicaid over time. Instead of expanding it, contracting it, giving states much more authority through block grants or per capita caps on how they configure benefit structures in their Medicaid policies so that the kinds of guarantees that Medicaid had under the Affordable Care Act get lost at the state level if states want to cut back, as they may have to as funding decreases on benefits for Medicaid beneficiaries. The Congressional Budget Office estimated that something around 12 to 14 million Medicaid beneficiaries newly covered under the Affordable Care Act will lose coverage with this change. The exchanges, well, remember, they depended on subsidies to people who otherwise couldn't afford to buy insurance between 138% and 400% of poverty. And they depend on guaranteed issue, community rating, and a mandate. Otherwise, it can't work mathematically. America's Health Care Act takes that away. Instead of having income-based subsidies in the exchanges, those subsidies change to age-based subsidies, in which younger people get a certain amount, and then that increases with age, but nowhere near as much as is needed or provided through the subsidies in the current Affordable Care Act. Guaranteed issue, well, the administration says that that insurance companies still have to issue policies, but it doesn't provide the mandate anymore. That goes away, which means that the premium structures in the policies will grow out of control. The sicker people will stay, the well people will flee, and we'll end up with unaffordable insurance. In addition, the Affordable Care Act changes the definition of the health benefits that make up an insurance policy. The Affordable Care Act required essential health benefits, 10 categories that an insurance company had to cover. Under the America's Health Care Act, the essential health benefits go away, or they're left to the discretion of states. So states can narrow and narrow what has to be in the coverage in an insurance policy. What that means is that either the policies will grow more and more expensive out of reach because of the loss of the individual mandate and the unwinding of the market, or the policies will be less and less valuable because less and less is covered. And people in important categories, maybe people who need maternity care or certain cancer patients or people with certain pre-existing conditions, will now find that they can't find an insurance company that has that benefit because it's no longer an essential health benefit. On the accountability side, the kind of scrutiny and requirements for, say, the quality of the policies that insurance companies have now under the Affordable Care Act go away under the America's Health Care Act. And so the effect would be fewer and fewer people covered by Medicaid, fewer and fewer people finding affordable policies on the exchanges, even possibly the end of the exchanges as insurance companies flee, no longer able to offer affordable policies. The total effect, according to the Congressional Budget Office, in the most recent estimate I have, is something close to 23 or 24 million people losing coverage who got that coverage under the Affordable Care Act. On the other side of the Affordable Care Act, the fostering of integrative care, the focus on quality, the innovation, we don't know exactly what is intended now. Already, a very important source of innovation, the Prevention Fund, is zeroed out in the House version of America's Health Care Act. There's indications that the force of introduction of new payment methods to encourage integrated care, like the bundled payments, are not welcomed by this administration. There's a bundled payment expansion currently scheduled to take proven payment systems to encourage integrated care for hip and knee replacements and for cardiac care. That has been now withheld by the administration. It should have proceeded several months ago. They're indicating now perhaps endless delay. The other part of the Affordable Care Act structure has to do with funding. Where would the money come from for support of expansion of Medicaid through federal dollars? Where does the money come from to provide the subsidies and exchanges? And the answer was partly through savings. The Congressional Budget Office indicated that with these changes in payment, we would see substantial savings to the federal government through better care, but also through some new taxes, especially levying a tax on people of higher income, over $250,000 a year, to support the implementation of the Affordable Care Act. The America's Health Care Act, as passed by the House of Representatives, removes those sources of revenue. It takes away about nearly $1 trillion of revenue, while about $840 or $880 billion is saved by reducing coverage of Medicaid beneficiaries, by taking away the subsidies in the exchanges, and by increasing the cost to individual people in the marketplace, middle-class people, people of low income, who now find themselves high and dry, having to purchase coverage from their own pockets that formerly was paid for through the Affordable Care Act. Let me say one final thing about the Affordable Care Act. It's not perfect. It wasn't perfect when it was passed, and it's not perfect now. There are changes needed in the structure of the exchanges, for example, changes needed in the way the coverage is marketed to people, especially of a younger age and better health. Changes are needed in the way we've addressed prescription drug costs. We have not yet engaged the possibility of federal negotiation for prescription drug prices from drug companies and others. The Affordable Care Act has defects. Every one of those can be fixed, but not through the kind of repeal and replacement currently on the table. Thanks.